which we managed in our FMU unit at Harare Hospital, and it was a case of placenta abruptio.
Yogo, are you still speaking? Because you can't seem to hear you now. Are you there?
Can you hear me now?
Yes, you are back.
All right, thank you. Sorry, I had muted by mistake technology. So it is defined by as premature separation of the placenta after 20 weeks. And the main clinical findings are vaginal bleeding and abdominal pain, which is usually described as a profuse bleeding, which is accompanied by severe lower abdominal pain. And on examination, you would find a hardwood uterus with no palpable fetal parts. That's the clinical picture of placenta abruptio. Can be classified as acute, subacute, and chronic. And the one which I've given it an explanation to usually happens in the chronic type. It complicates about 0.2 to 1% of all pregnancies. And the pathophysiology is not completely understood, but there are generally two theories whereby there is a mechanical and the one which is due to defective deep placentation. So the mechanical is the one which explains what happens after trauma. Maybe a patient was involved in an RTA and comes with an placenta abruptio, where there is separation of the placenta due to trauma. Then defective deep placentation. This we can think of it in patients who have placenta abruptio when they have either severe preeclampsia or eclampsia. We think that it's because of the issues to do with the placentation. So I'm going to present a 19-year-old para or gravida one who was referred with antepartum hemorrhage at 40 weeks, at 34 weeks gestation. He had an initial scan which noted in our unit, which noted a high umbilical artery PI, and was referred for a placental disorder clinic from that initial. So the history of this patient is that she initially presented with PV bleeding, which was painless and only changed one pad with a few clots. So when she was sent to the FMU, she didn't have vaginal bleeding. The vaginal bleeding had stopped at that moment. This was an unplanned pregnancy, which was booked at 24 weeks. She started taking supplements in the second trimester. And when we saw her, she had 2 prior antenatal visits. So she had PIH diagnosed at 28 weeks and was currently being managed on nifedipine and methyl dropper. And when she presented to the unit, the BPs were well controlled. She didn't have any previous history of bleeding in the current pregnancy except this episode. The systems review was non-contributory. Her drug history, she was on antihypertensives, as I've mentioned, since 28 weeks, and she didn't have any family history of hypertension, neither did she have any family history of diabetes mellitus. So in summary, I had presented a 19-year-old para or gravida one, whom we are seeing now at 35 weeks. She initially presented at 34 weeks when she was referred to a placental disorder clinic. So on the initial scan, she had a high PI on umbilical artery interrogation a week prior to presentation. and she was known to be a PIH patient who was on treatment. So in examination, she was generally pink, normotensive, not in respiratory distress, no abdominal pain, and she was not having any vaginal bleeding at that moment. But when we continued with our examination, as she had come for a scan, we noted that she was having this huge clot in the retroplacental region, as you can see on that picture. I just selected a few pictures because when you try to send these presentations, because of the size of the picture, sometimes it's difficult. So I just selected pictures of interest for this discussion. So there I'm also showing another picture of the clot which was noted in this patient. Then we went on to interrogate the umbilical artery, and as you can see there, the patient had a raised PI in the umbilical artery there. I think this is just a repetition of the same wavelength, which I was trying just to magnify so that people can have an appreciation. So we also went on to sorry, that was sorry, this was a uterine artery. Sorry, I had said umbilical. There was the left uterine artery which showed some notching there. Then here we are now, we now have the umbilical artery Doppler, which was showing reversed end diastolic flow. Maybe let me try to put my pointer there so that people can appreciate. So we can see that this wavelength, we have a reversed end diastolic flow there, which we noted on Doppler interrogation on this patient. Then we went on to the nomograms of the middle cerebral artery, and you can see that there was redistribution because of what was going on in the placenta. We also interrogated the ductus venosus, which was still within the normal ranges. Then umbilical artery PI, you can see that it was above the 95th centile, which is abnormal again. And the resistive index was also above the 95th centile. So just to recap, this is a patient who was seen with painless vaginal bleeding. He had a scan a week prior, and they noted a high PI on the umbilical artery Doppler, but other Dopplers were normal, and apparently the clot was not noted. Then when she came a week later, we noted a huge clot in the retroplacental region, and abnormal Dopplers starting from the uterines and going to the umbilical artery Doppler, which had reversed end diastolic flow, redistribution in the middle cerebral artery, and whilst the ductus venosus was still within normal ranges. So our management was, we ordered an urgent delivery by cesarean section. So the patient went to have a cesarean section on the same day. It delivered a baby boy who had an APGAR score of 7 to 8 on 10 with a birth weight of 1,500. As of last week, the baby was admitted in NICU and the baby was doing well, and the mother was stable in postnatal ward. So as I've mentioned earlier, this is a condition whereby we have premature or preterm separation of the placenta before the delivery of the baby. And usually it complicates about 0.2 to 1% of all pregnancies. So there are generally people who have a higher risk of placenta abruptio, and these are people with a prior history of a placenta abruptio with the risk of recurrence being 10 to 15-fold higher, hypertensive disorders in pregnancy, and as a unit, I think these are patients whom we are going to be following up a lot, and we note that hypertensive disorders in pregnancy, they have a 5-fold increase compared to normotensive patients. Then structural uterine abnormalities, if the patient is smoking cigarettes or taking cocaine, and it's thought that also there are people with some genetic issues which predispose them to have these placenta abruptios. So in the acute phase, when we interrogate these patients with the ultrasound, the blood might be isoechoic, hence difficult to differentiate concealed blood to surrounding placental tissue, which I think is what happened with the first scan, whereby they just noted an abnormal uterine with an abnormal umbilical artery Doppler. However, they didn't note any clot. So in the acute phase, when we are doing scans for patients who come with an APH, we should always have a mind to say an abruptio can have an isoechoic appearance on scan. And in most cases, these are patients whom we see and have a scan and we say it's APH of unknown origin. Why? Because probably we didn't note the clot. So the location of the clots is usually subchorionic, retroplacental, preplacental, and with subchorionic being the most common. I thought ours was a retroplacental clot, but I stand to be corrected there. Then retroplacental hematomas have variable appearance, which can be solid, complex, hypo or hyper, or they can be isoechoic compared to placenta to the placenta. So it takes a high index of suspicion for the person who is doing the exam to suspect that this patient might be having a placenta abruptio, especially if it's in the acute phase. So complications of placenta abruptio, usually they present with hypovolemic shock if it's a major abruptio, which can lead to acute kidney injury, deep DIC, disseminated intravascular coagulation, which can lead to multi-organ failure. And so in most cases, they might, and these patients might end up having a peripartum hysterectomy or even death. In the unborn child, there is an increased risk of perinatal mortality and perinatal morbidity, secondary to hypoxemia, asphyxia, low birth weight, and preterm delivery. And also we can have fetal growth restriction if it's chronic placenta abruptio. So how do we diagnose this condition? Usually they present with PV bleeding, plus or minus abdominal pain, can be assessed with the uterine tenderness and increased uterine tone. The fetal heart rate we may have abnormalities in the fetal heart rate, or they can present with fetal demise. Uterine irritability and non-reassuring fetal status if we have a concealed abruptio. So they might come presenting with low abdominal pain without PV bleeding, and when we do the CTG or the biophysical profile, we see that we have a non-reassuring fetal status if we have a concealed placenta abruptio. So the placental pathology, acute abruptio is a clinical diagnosis. A retroplacental clot may be seen grossly, as we saw in our patient, though we think that this was now subacute placental abruptio. So after the clot is formed, an organizing retroplacental clot may be seen in less acute cases. So in acute cases, we might not see this picture because these patients usually presents as an emergency, and there's usually an emergency delivery. So management of these patients, it depends with the clinical status of the mother and the fetus. goal is usually to urgently resuscitate the mother and stabilization of the mother, then determine the fetal gestation and gestational age and fetal well-being. So stable mothers with non-reassuring fetal status, which is category 3 and 2, we want to expedite delivery, whichever way which is fastest at that moment according to the attending physician. Then stable mothers with fetal demise would encourage vaginal delivery if it's the best and safe at that moment. Then stable mothers with a reassuring fetal status, gestational age is to be considered. If less than 34 weeks, the aim is to deliver at 34 weeks. So we might consider tocolysis and corticosteroids while the patient is monitored in a fetal medicine unit to note any changes in the Doppler studies of this in the placental performance. Then above 34 weeks, we usually aim to deliver the patient. So because our patient, we thought that she had subacute to chronic abruptio, I thought I can just touch a little bit on that. So usually they have light intermittent bleeding and placenta, which the placenta might have ischemia and hence can lead to oligohydramnios, FGR and placenta and preeclampsia. So we are saying if we have a clot like what we saw in our pictures, we are going to have ischemia to the fetus, hence oligohydramnios. We know that when we are following up patients, we will have preeclampsia. They have reduced urine output because of the placental pathology. So the pathophysiology here is more or less the same, affecting the placental placental tissue. However, the pathophysiology is not the same. Placental ischemia will cause changes in the fetal Dopplers, as we have noted in our case. And histologically, the placenta may exhibit inflammation, necrosis, a vasculopathy, which is important as we are going to pick this through our Doppler interrogation, placental infarction, and intervillous thrombosis. So with our patient who had a reversed end-diastolic flow on the umbilical artery, you think that this patient actually had more than 30%, or only had about 30% of functional placental tissue which was left. Then when we go to the lab and imaging, coagulation status studies are usually normal for a chronic placenta abruptio. However, imaging can review placental hematoma, and serial examination may review fetal growth restriction. Sorry for that, Dr. Verenga, and oligohydramnios. Abnormal Doppler studies can also be noted, and CTG can arise from the abnormal Dopplers and abnormal CTG can arise from the placental pathology, which I had explained earlier, because of the vasculopathy and infections. So in conclusion, why did I choose to present this case? I think I chose to present this case because placenta abruptio, the way we were taught about it, is only an emergency which requires urgent clinical delivery of the mother, either to save the mother or to save the mother and the fetus. And usually it's taught as if we can't do anything more than just deliver the patient there and there. But following up on this patient, it shows that even if a patient has a placenta abruptio, the fetal medicine unit or the fetal medicine specialist still have a role to play, and probably advising the managing specialist on how to do and how to manage this patient. Secondly, it highlights that we have a lot of patients whom we think they just have this APH of unknown origin or idiopathic APH. However, we think that I think that a lot of these patients, we have some abruptios which will be missed either sonographically or clinically in the ward. So I would want to say to the FMU team, good work on picking this patient. Though I thought when we had an abnormal umbilical study on the initial examination, this could have raised concern about placenta abruptio, because this patient was discharged home because he wasn't having any bleeding, then came back for a placental disorder clinic a week later. So this condition could have worsened while the patient was at home. So I think with those few words, I would give back time to Dr. Verenga. Thank you.
Thank you so much, Dr. Marangwanda. I think great presentation. Let's open the floor to questions. Let's interact. I think it's an interesting case to interact with. So please go ahead and contribute.
So I think there was one question in the chat box which said, so is this early onset FGR? Thank you for that question. I think it's the patient. The patient was complicated, yes, with early onset FGR. If we note the birth weight, which was 1,500 at 35 weeks, since the patient was also diagnosed of PIH at 28 weeks, I think that this patient could have had some placental pathology, which later then predisposed her to have this abruptio at 34 weeks. So yes, I still think that she had early onset FGR, which could have been complicated further by this placenta abruptio. Thank you.
Okay, thank you so much. Then to just follow up, Mukala, the DV is used to determine delivery only after 30, before 32 weeks, because I think this lady who is way beyond 32 weeks. I think there was a follow-up question in the group which I've just answered. Dr. Marangwanda, do you think when this patient was seen initially, she didn't have an abruptio? Because the abruptio he showed us showed that it was still very fresh. And if you get more for hypo or anechoic abruptio, that means it's an ongoing abruptio. The moment it becomes quick, that means it looks like the placenta. That means the blood is fully clotted now. So don't you think when it's more for mixed it's a heterogeneous appearance. You can see areas of hypo and also areas of which are more of echogenic areas in there. Don't you think the patient didn't have it a week ago?
Thank you, Dr. Verenga. I think on that subject, in terms of these pictures, I might want more input from you, but because of those isoechoic and hypoechoic and hyperechoic picture, we thought she could have still have been having an ongoing abruptio, but with a week a prior history of bleeding a week prior, we thought it could have been a chronic abruptio, probably worsening as she came back for the scan. But yes, with what we have just said, it looks like she might have not had an abruptio a week prior, but with those hyper echoic sort of appearance, which are mixed with a hypoechoic picture, you would still want to argue that it could have happened earlier and still ongoing.
Okay. Fair enough. I don't know. Are there any questions coming from the floor concerning the case? So I think the most important take-home message also is to say we should look at the retroplacenta space. We have a talk on placenta examination. If you look at our YouTube channel, just to revise, go through the talk on placenta examination so that we are all conversant with the examination of the placenta, including the retroplacenta space, so that we can increase the pickup rate of the abruption cases. And also, women who persistently have notching in the uterine artery, very high PI notching. One of the biggest risks that these women have is placenta abruption. This is why in your counseling package, you should always advise women that they may develop abruption and tell them the features of abruption that Dr. Marangwanda described today. So always remember this, that a woman whose uterine artery do not soften, they are persistently high all the way into third trimester. Those women are candidates for placenta abruption. That increases the risk of placenta abruption. So that's a message you should always give to women whenever you see these women with persistently elevated uterine artery Doppler. This is why we want everyone to be competent in checking uterine artery Dopplers. Are there any questions or comments from the floor? Because if there are any questions or comments, maybe I'll ask Dr. Marangwanda to unshare so that please unshare your screen. Thank you. If there are no questions, I think let me proceed to give you some examples of reports writing. I think we started a talk on report writing 2 weeks ago. Of course, we had to interrupt to allow our registrar to present, but now we just want to continue this talk so that we improve how we report. Believe you me, nobody knows how difficult it is to scan. All people do is to read your report. If your report is badly written, it doesn't matter how good you are in scanning, people will judge you based on the report. It is therefore imperative that people should pay meticulous attention to the way they construct or to the way they craft the report. So this is why I'm having this talk today, to try and improve the way we report. So your report should always have something we call risk profiling. Pregnancy is about risk profiling. The risk of the pregnancy should be declared and known so that everything that is done after, it is done in the right context. Without a risk profiling a patient, your report doesn't make sense, or some of the things that you are going to say in the report will not make sense to anyone. Or you may not make sense of what you have seen on the scan because you do not know what the risks are. So always remember this, that risk profiling is a very essential part of the report. So every report that you produce should have what you call something we call risk profiling. This is how we can do it depending on the situation. Thank you for referring XX to FMU. Sorry, not for FMU there. I should correct that to FMU. Sorry. Don't know what is happening here. Let me just briefly exit here. That since this is going to be shared on our YouTube channel. FMU so that this correction is done right away. So thank you for referring XX to FMU. This is, so many grammatical errors. This is AX pregnancy with Y, healthy children at home, and Z previous unfortunate miscarriages. That is if they are miscarriages. This is very important to know the context because, for example, you are dealing with a woman who has had 10 pregnancies but 0 babies. Definitely the way you are going to approach this pregnancy is going to be different from somebody who is coming for a 50th pregnancy and she has 4 healthy children at home. The risks of these pregnancies are different. And our approach to the whole pregnancy management plan is totally different. Because for somebody who has had them 88 pregnancies and probably going all the way to term, but she has been having IUFDs, you're not going to approach it the same as somebody who has been having, who has had 4 children delivered natural at 40 weeks. The risks of these pregnancies are different. This is why this has to be flagged from the top. Then when he says that previous miscarriages, this is very important because if somebody has been losing them recurrently, that means this is a candidate who should be monitored in the preterm surveillance. But if you do not flag this information, you are going to miss this opportunity of managing this woman in the right way. Some women will need some intervention, some will need progesterone, some will need some form of intervention, some will even need a stitch. But as long as you don't take history and flag the risks, you are going to miss that the woman needs a stitch and the woman will miscarry again. Previous pregnancy was complicated by hypertensive disease of pregnancy, or it was complicated by IUFD, or it was complicated by recurrent miscarriages, or it was complicated by diabetes or gestational diabetes, or a previous baby, a trisomy 21, 18, 13, or an X congenital malformation. X means the name of a congenital. For example, the baby had gastroschisis, or the baby had exomphalos, or a ventriculomegaly, or a holoprosencephaly. Why are we doing this? We are putting the risks in context. For example, a woman who has had a hypertensive disease of pregnancy has probably a 25% chance or more of having it again in this pregnancy. A woman who has had an IFD before is more likely to have it again if we do not watch the current pregnancy. The same applies to recurrent miscarriages. The same applies to diabetes. A woman with diabetes has diabetes. So in this pregnancy, you also have to manage a pregnancy complicated by diabetes. A woman has had GDM is more likely to have it. That means you need to check for GDM in Oh la la. Sorry guys, I was told there is no sound. There was no sound at all when I started. So what I'm going to do is, I think I have to restart because I mean, you guys didn't hear anything. Nobody posted anything. I wonder if there are people in the meeting because I've just been told that I didn't have a sound. I think now I have a sound. Is that correct? Hello, can you guys hear me now?
Loud and clear.
Yes, we can hear you. We heard you
So,
up to a certain point.
so why were you quiet? Because I didn't. I went on and on when you guys were quiet. Fair enough. Let me continue then. So I was saying today I'm going to give you examples of how to write a report. So in the beginning of every report, there should always be something called the risk profiling, which is what I'm going to take you through. I'm just going to redo everything because you didn't hear anything. There's something called the risk profiling, which you should do on all patients. So risk profiling, that means you are going to highlight the risk at the top of your summary of findings. Before you go on to tell people about the scan, you risk profile the woman. These are examples of how to risk profile a woman, which I'm going to take you through now. For example, you start by saying, thank you for referring XX to FMU. This is year X pregnancy with Y healthy children at home and Z previous unfortunate miscarriages. You are mentioning the issue of pregnancies because it matters how we manage somebody. If somebody comes to us and tells us that I have 6 children in a trot and none of them is alive, compared to somebody who tells you this is my 6 children, a 6th pregnancy, I have 5 healthy children at home and all born naturally at term. It matters how we are going to approach this pregnancy, including recommending the care plan. If somebody tells you that I've had Z previous unfortunate miscarriages, again, it matters. You want to know, is this a candidate to be followed in the preterm surveillance clinic or not? But for you to know this information, you should have asked the woman this kind of information. Then previous pregnancy complicated by hypertensive disease of pregnancy, or IFD, or recurrent miscarriages, or diabetes, or GDM, previous baby had trisomy 21, 18, 13, or an X congenital malformation. All this information is important in risk profiling. If somebody has had a hypertensive disease before, they are more likely to have it. The same way with diabetes, the same way with previous trisomy, the same way with congenital malformation, they are more likely to have it. So pregnancy profiling is key. In this pregnancy, she has gestational hypertension. We are not talking about the current pregnancy. Or she has diabetes, or and is on X-meds, the condition is well controlled and controlled. Always state the medication that somebody is taking. Don't just say somebody is hypertension and they're not going to tell us what medication they are taking. What about if they are taking losartan? You are going to come to encounter oligohydramnios and you will not be able to explain why there is oligohydramnios. So mentioning the medication somebody is taking is very crucial because some of the medication could be the explanation of your ultrasound scan findings. But if you do not mention them, you are going to wonder as to why these anhydramnios. Aneuploid screen was done or not done using combined tests or NIPT, the risk was low or high. This should always be mentioned so that when you come across soft markers, for example, somebody who has the NIPT, if I come across a short as a bone, I'm not going to panic and tell the woman that, look, you are going to have a baby with Downs because the risks are less with an NIPT result. The same way, if I just see mild hydronephrosis in a patient who has had NIPT, I'm not going to worry the woman about Downs. But if the woman is not screened, then I have to ignite this discussion and say, look, Sometimes babies with Downs could have things like this. Do you mind if we screen you, if we order NIPT, or even if we do an invasive testing? So risk profiling is very important because it will allow us to craft a care plan as well in terms of trying to explain the ultrasound findings. For example, a woman with gestational hypertension, you are not going to get surprised why the uterine PIs are high, or we are not going to get surprised if you encounter fetal growth restriction. But if you do not know this, everything will become, it will look like you are discovering a new planet every time, because you'll be wondering, why is the baby small? The baby is small because the woman is got a vascular pathology, has gestational hypertension. The baby is big because the woman has got diabetes, which is not well controlled. But if you do not know this information, you won't be able to make head and tail of what you are looking at. Pre-eclampsia screen was done or not done, the uterine PI were high, and the PAPI was low, and the PLGF was low. Why are we mentioning pre-eclampsia? Because pre-eclampsia is the most commonest condition that you guys are encountering. Women should be offered pre-eclampsia screening and be put on aspirin. You go on to mention if she's on aspirin, if she was high risk, you want to mention if she's on aspirin or not. When you say pre-eclampsia was done, if it was done, then the next sentence should be she was low risk or high risk. If she is high risk, you want to mention whether she's on aspirin and calcium, or she's on aspirin alone, and so forth. Then you go on to maternal assessment. To say on maternal assessment, is she normotensive? Does she have elevated blood pressures ranging from what systolic blood pressure to what diastolic blood pressure, from diastolic blood pressure to what the blood pressure? I think these are grammatic errors. You should read that diastolic blood pressure there too. There is no top. Then we want to know, is she stable, or is she symptomatic or asymptomatic of severe preeclampsia? So this is the risk profiling that should be at the top of your report summary. When you are now summarizing your findings on the report, you're putting the conclusion to your report. All women should have this risk profiling sentence. Please do not start your report by just writing the ultrasound scan findings. That's not the way to do it. Just say, yes, on today's scan, That's not the way to do it. That's the wrong way. The correct way is you risk profile the patient. This is why you are taking history. This is why you are taking history. Please, we do not want to see reports without risk profiling. We'll be checking these reports from now henceforth to make sure everybody is being risk profiled as you are writing the reports. This is why you are taking the history. Use it so that you can make heads and tail of what you are saying, so that you can recommend a care plan that makes sense. Then from there, you can craft your report differently. That is after this paragraph. The next paragraph, you are telling us about the scan findings. On today's scan, this is for normal growth. The fetal growth is within normal limits. If you are seeing the patient consistently or serially, you have to mention if growth is consistent with the previous assessment. When you are commenting on fetal growth, you say fetal growth is consistent with the previous, is within normal limits, and consistent with the previous assessment. The amniotic fluid volume and fetal Dopplers are within normal limits. On fetal Dopplers, you have to put in brackets the fetal Dopplers that you have assessed. Do not put the Dopplers that you have not assessed. Are within normal limits, as well as maternal Dopplers. Now that when we started, it was not our policy to check uterine Dopplers for everyone, but now it is. That everyone who comes to our units should have uterine artery Dopplers assessed. So, and as well as maternal Dopplers. Then you put uterine arteries in your brackets like this. So this is a conclusion for normal growth. Then you mentioned that good fetal movements were noted on the scan. Please get in touch with us if there are any questions. This is just an ordinary fetal growth assessment report. However, because we are a fetal medicine unit, the review has to be put to say, we will review again if it is a routine scan at 36 weeks, 32 or 36 weeks, depending on when you have seen the patient. For routine fetal well-being assessment. This is for an uncomplicated pregnancy. An uncomplicated pregnancy, no risks on the pregnancy. She has just come for a growth scan, and this is how we are going to conclude. Then please get in touch with us if there are any questions. So that's a normal growth assessment. This is an example where there is a problem of the placenta. On top of commenting the growth and the Dopplers, we have to go on and comment the placenta. There is a placenta previa with the main bulk of the placenta being posterior and an anterior edge covering the internal os by an anterior edge which is covering the external os. It should not be by, but it should be with an anterior edge covering the os and extending, covering the internal os and extending by 3.77 centimeters. The question is, why are we reporting like this on placenta previa? We want to know by how much the part which is crossing over the os is extending by. Was it to give us an idea to say, if it is just touching on the os, and we are in very much in second trimester, there's a possibility that the placenta could move. And also the incidence of bleeding for such cases is low compared to the ones that are really covering. So we want to be able to advise and also to come up with a care plan for the patient if this information is given. Edge of the placenta 3.7 centimeter beyond the internal os. I think that's the same message I put on the top there. We say this is unlikely to change during pregnancy, but placenta position will be checked at next scan. We'll review at 28, 32, and 35 to assess fetal growth while being in placenta position. XX is aware of, if she has any bleeding, to report to the hospital. This is the advice we give to the patient. We also inform the patient that you are more likely to bleed because your placenta is covering the os. That's a conclusion. But it's not put as it is. You again have to risk profile. You have to comment on the fetal growth. You have to end in the right way, in a very polite way, to say, please contact us if there are any questions. We do not hide our work. And be willing to be contacted concerning your findings. Don't scan and hide your work so that people have no means of contacting you concerning what you have done. This is an early pregnancy report. After doing the risk profiling, on today's scan, there is a single viable intrauterine gestation. The fetal crown rump length measures XX millimeters. Therefore, we cannot perform the assessment of risk for chromosome abnormalities today, as the pregnancy is less than 11 weeks gestation. We have explained these findings and arranged for another appointment in the next XX days. It might not be 10 days, It depends on how far the pregnancy is. So I'm going to put XX days there. When we review again, please get in touch with us if there are any queries. Some may ask and say, why are we mentioning all this? Because in fetal medicine, every woman should be assessed for the risk of chromosome abnormalities between 11 and 13 weeks plus 6 days. So if you happen to scan a woman before they are 11 weeks at least, you should always bring them so that we see them between 11 and 13 weeks plus 6 days for pregnancy risk assessment. So please take note of this. Don't scan women and tell them how you can go come at 20 weeks when you see them at 8 weeks. That's not the fetal medicine way. In fetal medicine, all women should come between 11 weeks and 13 plus 6 days for pregnancy risk assessment. That includes aneuploidy and also preeclampsia and other pregnancy-related complications. So let's take note of that. Miscarriage. Unfortunately, the findings on the scan are suggestive of a miscarriage. The maximum gestational sac diameter is XX millimeters, and the fetal pole measures X millimeters. There is no evidence of fetal heart motion on the scan. These findings have been explained to the couple, and options for further management, including expected medical and surgical management, were discussed, and an appointment for their chosen method will be arranged. Please contact us if there are any questions. You can see that in this conclusion, there is also a management plan outlined here, and a care plan to say what is going to happen to the couple. I'm looking at my time. It's now 2 to 9. I think the conclusions are becoming more and more complicated and sophisticated as I continue. I'm thinking of stopping here, and I'll continue next week, unless if there's any of our register present or anyone has an interesting case. If you have an interesting case, you can interrupt my presentations and present your case, but I would like to continue next week with more sophisticated conclusions so that we can see for ourselves how we can craft different kind of conclusions, the more sophisticated and difficult ones. Otherwise, thank you so much for taking time to attend, and see you next week if there are no further questions. And thank you, Dr. Marangwanda, for presenting that case. Very interesting. And yeah, otherwise, thank you so much. Cheers. Bye-bye.